Welcome everybody to our November orthopedic grand rounds. We'll start off as usual with a couple of thank yous and kudos. And some of those includes ones that we did not have time to get to last month. And the first one is from one of our R1s, Susanna Olson. And Dr. Olson, along with Dr. Ingalls and Shigley, are all thanking Eli Bonzel for the help he provided when they were the Block 1 Trauma Day interns, facing issues, not surprisingly, amongst other things, with epic access. And Susanna went on to say, I don't think any of us would have been able to make it through pre-rounding if Dr. Bonzel had not been there. And this is a testament to Eli's leadership and also the culture of the residency. So thank you, Dr. Bonzel and Dr. Olson. The next one is for John Bartoletta. And this is from a labor and delivery physician who said, I had the pleasure of consulting with your resident, John Bartoletta, on a pregnant patient who experienced a distal radius fracture. Our labor and delivery nurses commented on his kind bedside manner and clear communication with this patient. Our specialties don't cross over very frequently, but I wanted to let you know how much we appreciated Dr. Bartoletta's care and expertise. Thank you, John. Next one is from Dr. Jerry Wong to John Yamaguchi, and it says, Dear John, thank you for taking such good care of our patients when you are on call. One of our recent patients, a retired Harborview nurse, gave you the highest compliments on the great care she received in the ED by you. Thank you, Dr. Yamaguchi. I have one from a patient of mine who thanked Dr. Coale, who noticed during our clinic visit that the patient had an irregular rapid heart rate and strongly suggested that the patient's daughter take the patient to the Montlake ED, where it was noted that Curtis was correct and the patient underwent cardioversion, and they felt that Curtis may have saved this patient's life. So thank you, Dr. Coale. And the last one is for multiple residents and Aaron Chirones, who had another wonderfully successful year of Academy video publications. We had a 100% success rate, and the following residents all had videos accepted by the AAOS: Dr. Benner, Bonzel, Coale, Chaparro, Koo, Mills, and Scheffelbein. And thank you to all of their faculty mentors who helped with those. Couple of quick announcements. You can find all the dates on your calendars, on the department calendar. We have the Garrett lectureship coming up, and Kurt Spindler, a really well-known, renowned sports surgeon and clinical investigator, will be our guest this year. We also have our holiday party at the Burke Museum coming up, which you have all received an invitation to. I would ask the faculty, if you have not donated in a while or you're not on the regular monthly schedule, please consider donating money to the discretionary fund. It is the only way to fund that sort of party. We have tried for probably 25 years now to convince the university that there should be other ways to do that, but it can only be done by donations. So thank you. With that, we should get on with grand rounds. And I'm really pleased to invite Dr. Max Coale, one of our residents who is interested in foot and ankle surgery and will be doing a foot and ankle fellowship, and Dr. Michael Brage, who is one of our foot and ankle attendings. And Dr. Brage, I would imagine, has to do the highest volume and the most complex ankle reconstruction if not just in the Northwest, possibly even beyond. And so, Max, could you start us off?
Sure thing. Share my screen here. All right, welcome everybody. Good morning. Thanks for logging on early and paying attention. Welcome to November Grand Rounds. This is understandably a rather niche topic, but as you'll see throughout the presentation today, the rate of total ankle arthroplasty is certainly on the rise throughout the United States. And this means that there's also likely to be an increase in revision procedures that are needed. And without further ado, we'll talk about revision total ankle arthroplasty. Just as a quick outline, we'll first start off with talking about ankle arthritis and the two main techniques used to treat it, which is either an ankle arthrodesis fusion or an ankle arthroplasty. Next, we'll briefly touch base on the history of the total ankle arthroplasty throughout the United States. It's been fraught with difficulties throughout the way, and we're now actually on the 4th generation of total ankle implants. And by learning about the pitfalls that they've had throughout the years, we can better explain and understand how best to treat their failures. Then we'll move on to total ankles in the United States and the trends that we're seeing over about the past decade or so, which are very telling. Then I'll turn it over to Dr. Brage, where he'll discuss the revision process and the algorithmic approach he uses to decide what implant or what technique will be needed to treat a failed implant. And then finally, this is a field that has a paucity of data, and future research is absolutely critical. And so we have a little bit on where the future holds. So first off, ankle arthritis. It's something we see all the time, but it's a common end-stage result of a multitude of etiologies, most notably post-traumatic arthritis, although primary osteoarthritis, inflammatory or rheumatoid arthritis, and infectious disease are all causes of this. It's a disabling disease of the tibio-talar joint only that leads to a significant pain and impaired function in patients that experience it, with actually similar pain, morbidity, and loss of function as hip arthritis in a number of studies. Touching base on that, the more commonly discussed hip and knee arthritis, the joint of note is a two-bone system, typically without any history of prior trauma. The soft tissue surrounding the hip or the knee is generally not that compromised, and the tissue envelope is much more substantial. In contrast, symptomatic ankle arthritis is typically post-traumatic in nature, which leads to a very compromised soft tissue envelope with significant scar tissue accumulation. In addition, although the tibio-talar joint does consist of two bones, like the hip or the knee, it also is attached to 27 other bones and 32 other joints below the ankle and the foot that have a drastic impact on the alignment and therefore the function of the future implant. Initial treatment, like other forms of joint arthritis in the body, is non-operative. So this includes things like bracing, steroid injections, oral anti-inflammatories, and physical therapy. However, advanced disease typically does not respond well to conservative measures, and if pain and disability persists, surgical interventions are considered. There have been many different types of surgical interventions that have been described in the literature throughout the years. However, the two main interventions that have really held out and become most popular are either ankle arthrodesis or total ankle arthroplasty. Touching base quickly on ankle arthrodesis, traditionally, this is the surgical intervention of choice. Eliminating the painful joint space eliminates the pain. However, this was especially true for younger patients, those with higher demand jobs or who were more active, or heavier patients who thought that they would put too much stress through the implant. The fusion of the ankle joint provided a stable platform for the patient to weight bear and ambulate while simultaneously eliminating the pain associated with the arthritis. This was borne out in the literature to be true. Many patients were largely pleased with the outcome of their surgery, although it comes at a significant cost. The cost is obvious. It's the loss of range of motion. This can be the result of a ton of different etiologies, as we described earlier. However, it does lead to acceleration of subtalar and midfoot arthritis. That could lead to further fusions down the road. It also leads to a slower walking speed. Multiple studies have shown that after fusion of the ankle joint, patients didn't move as quickly and they didn't move as symmetrically, where their ground force reaction curve was not as symmetric from side to side. Traditionally, total ankle arthroplasty was described as the ideal patient as a low demand, elderly, thin patient that didn't have any deformity and had a primary disease of osteo or rheumatoid arthritis. However, this is changing, and the traditional notion of what an ideal patient is has been somewhat of a moving target over the past decade. Currently, through a multiple different amount of studies, we're seeing that it's not necessarily just the low demand patient. We're putting more ankles in younger patients who desire more range of motion, who want to maintain their independence. It was elderly patients. Well, actually, the most prevalent age group is 55 to 64-year-olds who are receiving total ankle arthroplasties. I don't know if anybody on this call would necessarily define a 55-year-old as elderly. Thin patients? Well, actually, there's been 3 studies that have looked specifically at patients' BMI and weight on the survivorship of a total ankle arthroplasty. And then actually in obese patients and non-obese patients, in 2 of those 3 studies, they had completely similar survivorship, complication rates, infection, failure as the non-obese patients. And so it's not necessarily that patients need to be considered to be so thin anymore to receive this implant. And what about deformity? Well, it used to be if you had any sort of deformity, this was a non-starter. You couldn't get a total ankle arthroplasty. Today, we're realizing that as long as the deformity can be passively corrected or pre-corrected with a surgery beforehand, their patient usually ends up being a great total ankle arthroplasty candidate. So it makes it confusing. What makes it more confusing on who to pick for a total ankle arthroplasty is that there's considerable variation in patient selection throughout the world. For instance, in Scandinavian countries, almost 50% of patients receive total ankles for inflammatory arthritis. In New Zealand, 90% of the cases are for post-traumatic or primary ankle osteoarthritis. And then here at home in the United States, almost 80% are for post-traumatic or primary ankle osteoarthritis, while only 15% are for inflammatory arthropathy. This highlights the difficulty in identifying a consensus opinion on the ideal arthroplasty patient. Moving on to total ankle arthroplasties, what's good about them? They've emerged as a viable treatment option for patients with symptomatic tibio-talar arthritis who require operative treatment and wish to avoid the physiological costs associated with ankle arthrodesis, including the previously mentioned loss of ankle range of motion leading to abnormal gait patterns. Ankle arthroplasty typically works to maintain pre-operative motion instead of restoring normal, quote-unquote, ankle range of motion due to the large effect that the surrounding soft tissue envelope has on the function of the joint. Recent data has shown that self-reported outcomes from 2005 to 2011 promoted total ankle arthroplasty as providing better relief and patient-reported functional outcomes at 3 years after treatment when compared to arthrodesis. It also preserves a higher walking velocity and an increased stride length and cadence when compared to arthrodesis. That sounds great. However, there are certain costs associated with it. Some studies have shown promising data that up to 86 to 92% of all total ankles have survived follow-up at the midterm level. However, there's a high risk of failure, and even with some of our most common generation of implants, our most recent generation of implants, there's still an annual rate of 1.2% failure. And despite being commonplace now, it took about 20 years of innovation until wide adoption of ankle arthroplasty was accepted, as early implants were fraught with an unacceptably high rate of failure. Here's the first ankle arthroplasty that was put in. Yes, what you're looking at is a femoral stem from a hip arthroplasty that was implanted into the tibia and an acetabular cup that was cemented into the calcaneus after a talectomy. This was done by Lord and Murat in the 70s. That was abandoned quickly, and most of the first generation implants were developed in the 1970s. There were variations on a 2-component design of a polyethylene tibial component and a metal talar component, and they were all cemented. They were split between constrained and unconstrained components. Failure of these implants was noted to be at least 50% by 10 years, mostly due to subsidence, pain, and aseptic loosening. Why were the complication rates so high? Well, preoperative issues were a significant portion of this. They were mainly related to patient selection. Patients with rheumatoid arthritis, who received a large proportion of the fourth generation of implants, often have pronated feet, ligament incompetence, and many of these patients did not have their hindfoot deformities corrected before their total ankle arthroplasty, which led to an uneven loading of the implant. Also, most first-generation total ankle arthroplasties were cemented, which were associated with poor outcomes as they required more bone resection, which led to increased loading of the weaker metaphyseal bone. In addition, the tight operative window for a total ankle arthroplasty made proper cementing difficult to achieve. Finally, the constrained designs were subject to increased rotational forces across the bone implant interface, which led to aseptic loosening, while the unconstrained devices of the time were associated with instability and impingement. So you kind of were lost either way. Intraoperatively, many of the bone cuts that had to be made were freehand. There weren't specific cutting guides made yet by industry, and this led to a greatly increased risk of implant malposition. But these results of the first generation of ankle arthroplasty were so poor that the literature at the time recommended that they be completely discontinued and never implanted. However, the development of uncemented fixation for hip and knee arthroplasty led to a renewed interest in total ankle arthroplasty in the late 80s and 90s. This second generation of total ankles were a mix of both 2 and 3 component systems that sought to more accurately reproduce normal ankle anatomy, joint kinematics, ligament stability, and mechanical alignment. The agility system, which you see all the way on your left, was a semi-constrained design, designed actually in the United States, that consisted of a titanium tibial component with an attached polyethylene articular surface and a cobalt chrome talar component. In comparison to the first generation implants that were focused only on sagittal plane movements, the agility allows some axial rotation and medial to lateral translation to occur, as the talus is smaller than the tibial cup-shaped articulation. It does require a syndesmotic fusion, however, to support the tibial side of the implant. The other 2 main second generation total ankle arthroplasty implants, the STAR and the buccal pappus ankle replacement systems, are much more reminiscent of what we see in modern total knee replacements, where a mobile polyethylene component is sandwiched between the tibia and the talus, and this provides rotation between the tibial component and the poly, and flexion extension between the poly and the talus. These showed improved results over the first generation of total ankle arthroplasties, with one study actually showing a 20-year survival rate of up to 75% in the buccal pappus group specifically. Such results of the second generation designs rekindled enthusiasm for ankle replacement. We have now better understanding of hindfoot biomechanics and the importance of the bony and soft tissue alignment, in addition to further design modifications resulted in the modern third generation of implants, which are characterized by the use of ligaments to retain stability, the need for anatomic balancing, and minimal bone resection. Today, we have a multitude of different ankle arthroplasty implants on the market. This is the third generation. We actually have 4 now, but the third generation all utilize a 3-component semi-restrained system, almost all, with a poly-on cobalt chrome surface with both fixed and mobile bearings. There are very small variations between the different generation designs, most notably in terms of a stemmed tibial component or the option for screw fixation. There is, however, at this time, no consensus on the superiority of fixed versus mobile bearing devices. We're now onto the 4th generation of total ankle arthroplasties, and recently, over the past few years, these have been reintroduced into the US market, and they specifically focus on retaining as much bone stock from the tibial side of the construct as possible. This has been shown to be important in the preservation of the implant, and like all principles of arthroplasty, leaves more bone stock available for possible future revision procedures. Just looking at these 4 implants, you can see the tibial side, which is the one towards the top of each picture, is very sleek, streamlined, small, and it takes up a lot less space in the tibia. So moving on to total ankles in the United States. There's actually this great study published this year by Carzon et al. That looked at the total amount of total ankles completed in the United States using an IBM market scan. And this showed that the annual case volume and incidence of total ankle arthroplasty is on the rise. This is the blue line on the graph in front of you. Between 2009 and 2019, the total amount of total ankle arthroplasties implanted in the United States rose by 136%. This is mirroring the observation that the prevalence and incidence of ankle osteoarthritis is also expected to continue to rise alongside an aging and more active population. When looking just at the Medicare population, this trend is also mirrored, as the volume of total ankle arthroplasties, as defined by the red line, sharply increased since 2006, which is associated with a decrease in the arthrodesis volume at the same time, which is defined by the blue line. This trend suggests that in the Medicare population, more and more ankles are being replaced instead of fused. Going back to the Carzon et al. Study, it's showing that the procedure is also following the larger trend in orthopedics towards more outpatient procedures. In the same study, as ankles were being implanted, the number of outpatient procedures greatly increased as well. This is the gray line in front of you. We can anticipate that the volume and incidence will likely continue this upward trajectory as the complication profile associated with total ankle arthroplasties decrease and the longevity of the implants begin to increase. An interesting finding in the study was that despite ankle arthritis developing at a much less frequent rate than either hip or knee arthritis, when adjusted for the same study period between 2009 and 2019, the annual growth rates of total ankle arthroplasty were found to be 2 times greater than either total knee arthroplasty and 3.6 times greater than total hip arthroplasty. This finding is possibly reflecting a greater trust in the procedure among surgeons in the United States for their patients with ankle arthritis, regardless of the etiology. Now, armed with the understanding that the history of the total ankle arthroplasty procedure and the expected increase in total number of total ankles implanted, it's necessary to recognize that revision surgeries will likely soon be on the rise as well. There are a multitude of studies reporting on individual types of prostheses, but a recent meta-analysis reported that 9.8% of all total ankle arthroplasties have required revision or conversion to arthrodesis at about 5 years on average. Other studies presented a range of 4.6% to 11% of all total ankle arthroplasties needing revision at a minimum of 5+ years of follow-up. At the 10-year mark, almost 20% have needed some sort of revision procedure. Finally, there's been shown to be a 1.8 time increase in the relative risk of undergoing a revision surgery that requires either the patient to be non-weight bearing and or removal of the implant when compared to ankle arthrodesis for ankle arthritis. All this is to say, we certainly haven't figured out total ankles yet. We're not out of the woods. In a 2009 study, 9 different total ankle arthroplasty complications were identified. These are listed on the chart above, with the highest rate of implant complications arising from implant subsidence and aseptic loosening, while the lowest rate of implant complication arose from deep infection, which was only in 1.7% of all cases. The other complications are listed here, including things like either intraoperative or postoperative fractures, non-union, technical errors for implant malposition, which, as we described earlier, that tight window makes it pretty difficult to implant these, or problems with wound healing. However, not all complications are made equal, and the data was stratified into 3 groups to better highlight the rate of failure and the subsequent need for revision surgery for any given complication. This stratification into the high, medium, and low-grade groups helped to define that some of the most prevalent complications, like aseptic loosening, indeed leads to revision surgery quite often, while the other prevalent complications, like subsidence, lead to a much lower rate of implant failure. On the other side of the coin, a relatively rare complication such as deep infection, present at only 1.7%, does, like in almost all arthroplasty procedures, lead to an exceptionally high rate of construct failure, despite being only 1.7%. If a deep infection is notified or identified in the patient, they end up needing some sort of ankle revision surgery 81% of the time. So now that the reasons for total ankle arthroplasty failure have been highlighted and identified, The question remains on what to do with this really tough problem. We've already elucidated that we haven't quite figured out total ankles yet, but how do we take care of the patients that have a problem with them? We have an algorithm that Dr. Brage uses often to help guide us to the correct procedure for any given complication. Starts off by determining whether the implant is infected or not. The rest of this grand rounds will be framed with this algorithm in mind, as different implants and techniques are used depending on the varying properties of the patient's implant and their specific anatomy. With that being said, I turn it over to Dr. Brage.
Hey, Dr. Brage, you're muted.
I can, yeah. Can you hear me now?
Sounds
Thank you, Dr. Coale. And thanks everyone for joining. My mouse seems to be quite sensitive. I'm trying to go backward. There we go. Anyway, so this is a simple algorithm. You can certainly find more complicated algorithms in the literature if you look, but this one serves me well. And you can certainly overthink the problem. We're going to go down the septic arm first, and then we'll go down the other side of loosening and subsidence and migration. So we'll talk about the diagnosis of deep implant infection, and then the option for treatments are listed here, including implant retention with poly exchange and antibiotics, explanting with spacer, reimplantation, arthrodesis, and amputation. Fortunately, amputation has dropped dramatically, and I can't even think of the last time I needed to do an amputation for a deep implant infection. So our techniques definitely are improving, but it was certainly a lot more common just 10 years ago. We've borrowed our infection algorithm from the Musculoskeletal Hip and Knee Society, and what I see there is on the top of this little chart, the sinus tract with infection is the one that I see the most commonly in my clinic. And I think that's because the ankle soft tissue envelope is a lot thinner. There are these other minor criteria that are available, but honestly, it's either infected with a sinus or a patient comes in with a painful prosthesis. We draw inflammatory markers on all of them. They're usually negative. And so what we're seeing is that we have a culture positive during a revision. And then we send it to infectious disease to determine whether it gets treated or not. So alpha defensin is something commonly used in hip and knees. I have no experience with it, but it is becoming something that is being used more and more for painful prostheses without a cause. We looked at our own infected total ankles with a few years ago, and this is actually from Dr. Hansen's series, and we found that that we had a 3.2% infection rate of all our total ankle replacements. That was 2.4% in primary total ankles, and our revisions had a 4% infection rate. The findings were 21% underwent amputation, which is tragic, but it was certainly common back in those days, and we are getting better. 65% were able to be revised to an arthroplasty, typically 2-stage, and then 10% went on to a fusion. Mark Meyerson's group also looked at their infected total ankles in the same time. Their study was noted that all infections treated with a poly exchange IND ended up recurring, and that needed an explantation and a staged revision. Their chronic infections, 13% were treated with primary revision, 33% went on to fusion, 33% with stage spacers, and 20% also with baloney amputation. The average time to revision TAA or arthrodesis after the initial infection was diagnosed was 7.8 months. There's a paucity of bacterial data, but most appear to be staph species. So deep implant infections, right now in total ankles, we just have limited case series. and broad conclusions are very difficult. And again, infection rates postoperatively may change with newer implants and improved surgical techniques. Here's a case that I wanted to show. A woman had her ankle implanted in 2007, and she became infected in 2015. What she had done is the ankle started to swell from polywear, and she literally let it burst through her skin. And then it became infected with a draining sinus. She required 2 debridements and cement exchanges, and she got 6 weeks of IV antibiotics, but the infection finally cleared. And it was our hope that with a proper brace that she would simply live with the cement spacer and brace it. But she said it was too painful and wanted a revision. And she didn't want a fusion under any circumstance. So you can see the challenge here is severe bone loss on the talar side. So she was off antibiotics for 2 months and the infection did not recur. So we went in to reconstruct her ankle with a new implant. What I typically do after the cement spacer is removed is I position the talar component to see how it sits on the residual calcaneus and talus. It looks good here on the coronal view, but on the lateral view, it's plantar flex. So we have to do something about that. And what we decided to do was use a talar rebar technique of screw and cement. So we put in some screws and we build a platform until the talar component sits to where we want it. So the screws are in place. We have a trial in now with the tibial component, and it's sitting very well. And in this case, polymethyl methacrylate is placed down and we wait till it cures. And this is her at 1.5 years, doing well and no signs of recurrence. So these things can be salvaged. It's complicated, but it can be done. We'll go on to the other side of this algorithm now when you have lucency, subsidence, and migration. And the bottom line is your experience and with these problems. You have to determine the amount of bone loss. If it's large, you may want to fuse it. If it's minimal, you can try to salvage it. So the arthrodesis options currently are hindfoot nails, plating, screws, custom cages, and allograft with fusion constructs. The problem with this is the non-union rates of fusions after total ankle replacements is extraordinarily high. It ranges from 11 to 42%, but most studies are on the higher end, 40s to 42%. These are challenging cases, and my own non-union rate is also quite high. So I do everything that I can to reconstruct it with a prosthesis because it seems to work better. Also, patient-reported outcomes are worse after a revision arthroplasty when compared to a primary. And really, there's no clear consensus of the benefit of a revision total ankle replacement versus arthrodesis in regards to patient-recorded outcomes at this time. There's still lots of work to be done. We'll go through some cases that I've experienced. This is a 37-year-old. She had an ankle fracture in 2008. It failed to heal, and she had multiple surgeries done on it. A total ankle replacement was done in 2015 in the community, and she did well for only a brief period of time. And she presented to us for evaluation. This is the Zimmer ankle replacement. It requires a fibular osteotomy. She had an elevated inflammatory markers, and in surgery, she had 11 white cells per high-powered field on the fresh frozen. So we took her out and put her in a cement spacer. Her cultures eventually did grow a coag-negative staph species, and she underwent the antibiotic. She did clear. Her inflammatory markers went down, and her wound healed, and she wanted to try another replacement. And so this was revised to this total ankle revision system. And she did well only briefly and continued to have severe pain. At this point, she did consent for fusion. So here in surgery, to take the implant out, we had to cut through the tibia with a cortical window, remove the implant, and we put a plate to restore the tibia there. And then this is the bony defect that we're dealing with. We took a femoral head allograft and cut it to the shape of the defect. And when we finally got it to fit, we put it in. And we then fused it with an ankle fusion nail. So this is the final construct as it looks. And this is her 6-month x-rays. She has healed this. The CT scan was done to confirm it, and it does look united by all counts. And she is here now at 1 year. She's still in pain, but she has a stable leg to walk on, and she is fortunately in less pain than she used to be. So another reason to fuse a ankle after a replacement is severe deformity that's unreconstructable. In this case, this is a patient with rheumatoid arthritis. She has also very osteopenic bone and a deformity that's just too much. A CT scan was done to show the deformity. There's also what's left is reasonable. There's no periprosthetic ballooning osteolysis to worry about. And so we did design a custom cage for this particular patient. You get a CT scan. There are several companies out there that will print a 3D prosthesis for you. In this case, we used a cage with screw compression because I didn't think I could get a nail up successfully because of her deformity. And this is the artist illustration of the final construct. So we're in surgery. It's tedious. You have to debride until you can get the trowel placed. The trowel is placed here on the right. And on the lateral, we had to hand cut bone away with saws until we can get the trowel in place. Now we have the cage in. We do lather it in bone graft and other augments. The wires are through. We have the compression screws in. And I also felt the need to supplement that with an anterior plate. So we put a plate on top of this as well. And then just to get her hind foot in better alignment, we did slide it over with a calcaneal osteotomy. And here she is at 6 weeks with her routine visit. Things are in place and healing well. At 1.5 years, she returns. You can see on the lateral x-ray that there is a screw that's backing out slightly, but nothing has failed or broken. And at 2.5 years, the x-rays are unchanged. Her pain is gone. She is walking. And she asked if she had to come back anymore, and I told her she didn't. Otherwise, I think she's about 5 or 6 years out now. And then this is another case, a 54-year-old. She had post-traumatic arthritis. She underwent a total ankle replacement with gastroc recession. And again, she never did well. We also ended up fusing her hind foot. But her pain never went away. And the patient herself was convinced she had a titanium allergy. And she wanted her implant out and consented for fusion. And here in the surgery is the implant explanted. And you can see that there is no ingrowth on the implant at all. This is a titanium plasma-coated implant. And this has been my experience that even when they look good on x-ray, they often don't ingrow. And the industry is changing. They're getting away from plasma titanium sprays and are doing more custom printing. But it could also be that this implant was just painful to her because it didn't ingrow. Again, a allograft bone block was constructed. We put in some compression screws, and this is a stainless steel plate because of her concern for titanium. As luck would have it, she's 4 years out and came into clinic for evaluation, and you can see that she's nicely healed and solid. She has still some pain, as they kind of all do, but she is got a stable walking foot. Now, we'll go on to revision total ankle replacements. If the prosthesis is salvageable, I recommend you try to save it. And if the current prosthesis is not salvageable, then we recommend revision. In a lot of the times, the salvageable cases, we use a SPECT scan right now. There's not a lot of data yet, but it does seem to help to determine which side of the ankle is the problem. Revisions often include debridement and grafting of cysts, poly exchanges. Sometimes you have to reposition the components. And in some patients, in some papers, 84% of patients are asymptomatic at 1 year. Here's a case that is one of mine. I did a star ankle in this patient in 2014, and it lasted about 6 years or so, maybe 5 before it became painful. And you can see that there's periprosthetic cysts above on the tibial side of this ankle. And the CT scan is mandatory because it really can detail the cysts properly, and they're always much worse on CT scans than on plain film. When we got to surgery, though, the implant was stable. It was definitely attached. So the approach was to debride the cyst. You can see the Freer elevator and just see the enormous size of it. We grafted it with calcium phosphate cement, and we put in a new polyethylene liner, and we also did a revision gastroc. And here this patient is at 6 months. You can see the calcium phosphate cement is incorporating. He came back in 2 years. There's a little bit of recurrence of the osteolysis now on the lateral x-ray, but he remains pain-free. And he came in recently for a 4-year follow-up. The periprosthetic osteolysis does not seem to have progressed much. He remains pain-free and doing well. And he has good movement of his ankle as well. Here's another patient that came in recently, a 60-year-old. Her ankle was put in by an outside provider. She never felt right and had increasing pain. And you can see how the talar component has slid forward and she's broken her medial malleolus. This is the outside films that she brought in. So she certainly had arthritis of the ankle, and it was in varus. She probably had a little bit of flattening of her arch, but we don't have the foot x-rays. Her provider decided to fuse the subtalar joint first in a staged fashion. So he fused it with this screw construct. And then he did this total ankle. And this is his post-op x-rays in recovery room. And I would submit to you that he performed a technical error and should not have left the talar component in that position. So at 3 months, her x-rays are here. But by 6 months, your talus is already migrating and falling. And then by 9 months, when she comes to us, it's encroaching the talonavicular joint, and her medial malleolus fractured, likely because of abutment with the talus. The CT scan again shows the subtalar joint has healed. There's no periprosthetic osteolysis, and the tibial tray looks to be in good position. So we're going to try to save this implant by just revising the bottom piece. In this case, we hand cut the talus with saw. This is a revision talar component that we lay down and make sure that it sits well. To get a further stable platform for this prosthesis, the talonavicular joint was fused. It was already very badly damaged by the prosthetic anyway, so it needed to be done. And now the talar plate component can sit across that with some additional support. We fix the medial malleolus with a plate and screw construct. And then we laid down the talus, and I did put a small cement mantle underneath it just to give it instant support. She is at 6 months, doing well, feeling better than she had previously, and moving well. Now we'll go on to when the prosthesis cannot be saved and how to revise it. Unsalvageable cases usually involve large bony cysts, extreme subsidence of the implant, and simply mechanical failure. And again, on this particular case, you can just see the devastating bone loss on the tibia. It's even readily apparent on the plain x-rays. The arthroplasty options are these. I've used all these options to salvage cases, but my main prostheses are the InBone and Envision systems. This is a 75-year-old who had multiple surgeries on her foot for post-traumatic arthritis, and a total ankle was placed in 2021 at an outside institution, and it looks good. But simply by October 21, you can see how everything has just collapsed catastrophically. The talus has subsided down, and the tibial component is also grossly loose. She had normal inflammatory markers. The CT scan again shows that the bone quality around the implant seems okay. And her limb alignment here is also acceptable. So at revision, we took the implant out, it fell out, there was no ingrowth. I'm laying the talar plate down again, and again, it's sitting well. So minimal work has to be done on the talus. The cutting guide is placed. We're going to take a fairly healthy portion of the tibia because of the previous implant had compromised the bone. This is the tibial sizing tool, and we are measuring it for the largest prosthesis that the company makes. And then these are the trials that are in, and you can see how we were lucky to get a cortical rim of bone that will allow the talar component to sit. So again, I used the screw rebar technique. I laid down a bunch of screws in the deficit, and we put the plate down until we get a nice stable platform. The tibial component goes in. The trials are placed to make sure everything is sitting well. Cement mantle is placed, and we allow it to cure. And this is she is now at 9 months. It's hard to read this, but she is happy with her outcome and is doing much better than previously. It's not moving much, but she's grateful for the amount of movement that she has. This is a long-term follow-up. I just wanted to show you that these can work. This is a custom agility that was placed in 2011, just as I came here. And unfortunately, you can see just between 1 year, the talar component is already sinking down into the calcaneus and talus. So it was revised to this implant. This is the InBone 2. And this is the x-rays in the 6-week period. And now he came in recently, 10 years later, for follow-up. And it looks very good. We did a side-by-side comparison to show that the implant has not subsided. It appears well ingrown and stable. So a long-term 10-year follow-up is readily achievable with today's systems. This 53-year-old had an ankle fracture and had 2 surgeries to correct it, but it got infected, an IND was performed, antibiotics given, and she was infection-free for 6 months when she came to us, and she was in severe pain. We staged this one. We took out her hardware. Her inflammatory markers were normal, and her cultures were negative, and her wounds healed uneventfully. And I revised her to this total ankle prosthesis, and she did only well for a little while. It looks well positioned here at 3 months. But you can see that over the next 18 months, the tibial component slowly slid in and deformed over time. So at revision, this is the explanted components. There was no bone growth on it. And so it's understandable how it subsided. So we freshened up the talar cut. We also recut the tibia with the cut guide, taking minimal bone. And then we put in a much larger stem. This system is modular, so you can construct as big of a stem as you need. I also put in some calcium phosphate cement to kind of hold it. These are our final images on the revision. This is her at 6 months doing well. And now she is 5 years out, continues to do well. And we're grateful that she is doing well and that she hung in there with us. Her motion is reasonable, considering she's had 7 or 8 surgeries on her ankle. This is a very severe failed total ankle with severe osteolysis and component failure. Her star was placed in 2013 and she did very well until this last year. She also recently was diagnosed with breast cancer. But here the implant is not only subsiding, the poly is dislocated out the back. That small fine wire is in the poly, so you can see that it's dislocated and free floating. Again, the CT scan shows just the devastating bone loss that occurs with these. And the talus is clearly compromised and broken as well. It was our decision that the talus couldn't be salvaged. So we again used CT scans, sent them into our company, and they designed this talus for us. It is made out of titanium. It has a ingrowth surface on the plantar aspect and screw holes so that we can fuse it to the calcaneus. So in surgery, the implant is out, and that is the images that you see show the plastic tailor trial that they provide. This is the actual prosthesis going in after we debrided it. We just want to make sure it's sitting well, and it seems to be. I pin the ankle because it's so floppy, and then we put it into the foot holder so that we can then place the cutting guide on. And this is the tibial cuts that we're making because of the severe compromised distal tibia. We're going to try to take as much bone away as we can. We're now trialing it, and this is the there's 4 millimeter and 8 millimeter tibial thicknesses now that we have available. I think we went with the 8 millimeter. This is a 4-stem component. I also use calcium phosphate cement to fill the bony defects. Now the trials are in with poly. It seems to be fitting well. And we put the actual talus in. We fuse it to the calcaneus. We do take the cartilage off the subtalar joint side of the calcaneus, and we use bone graft and biologics to help it heal. So in surgery, it's not moving much, but it's moving some. And she is only at 3 months, but she is here. It is healed. It is. She is starting to weight bear and rehabbed, and so far she is doing well. I wish I had longer follow-up images for you. Here's another one, fascinating. 77-year-old, no significant past medical history, BMI 30.27. Her ankle's in varus. Her total ankle was done in Spokane, and she did well for 4 months. This is the intraoperative x-rays that were provided to us, and it looks very well placed to me. And then, sorry for the theatrics, but she was mowing her lawn, and she felt her foot give out. And you can see that she has fractured her talus and dislocated her foot. CT scans confirm that her talus has been fractured through the body and head and neck. The head and neck went with the foot, and some of the body went with the talus. This was not reducible. We did a neuropathy workup. It was negative. We talked, our opening line was perhaps we should consider amputating this leg. She declined. We talked about fusion. She was not too thrilled about that option, and we offered her a total ankle replacement in multiple stages, which she accepted. So these are the 3D imaging. We used an imaging software to look at this more closely, and you can see how deformed this condition is. This is her other side, for which we are using to model her new talus. This is the imaging that is provided to show what our proposed reconstruction will be. We'll use another prosthetic talus. We're going to retain the tibial component because that looks good, and use a new polyethylene liner. And this is just imaging motion studies to look at whether we can do this or not. The prosthetic was used again with CT scans of the contralateral side, and the talus is then reverse engineered. Again, we're going to use an ingrown surface underneath and fuse it to the calcaneus. The company is very good about even determining what size poly you need. So they really help you out by providing a really detailed plan so that the surgery goes smooth. They also provide imaging of the implants. This is the implant, the new implant in final position, and then they also provide implants in final position with repositioned anatomy. So for us, we distracted her out with a fine wire fixator first. This took 4 weeks. And we put this on and we were able to get the foot reduced underneath the leg. At revision surgery, we took the fixator off. We left the tibial side in, took the talus out. This is the model of the talus in place. It's fitting well. Here's the actual talar component, fusing it to the subtalar joint. But as you can see on the left, it was unstable. It dislocated posteriorly, and we were ready for this. We knew that something was going to give, so we were ready to do a lateral ankle ligament reconstruction, and we used an allograft tendon weave combined with an internal brace to reconstruct the lateral ankle ligaments. And even doing that, it's still dislocated, so we had to reconstruct the deltoid ligaments as well. And we used the same technique. We used an allograft weave combined with an internal brace. And when we had done that, finally the ankle was stable. I got it. I rarely get recovery room films, but I was so nervous that I did so. Here she is at 6 weeks. The ankle is still reduced. Here she is at 3 months. Ankle's holding up well. We begin walking her now. And now at 6 months, the ankle remains reduced in good position and is clinically stable. So that's a really nice save in a really complicated situation. This is our last case. This is when a major ligament fails, the deltoid ligament. It is the strongest ligament of the ankle. You have to have a deltoid ligament intact or your ankle will not work. This is a 75-year-old. He had a subtalar NT infusion in 2017, a star ankle put in the community, and they even did a deltoid ligament reconstruction. And he comes to us in 8 out of 10 pain like this. He's in obvious valgus. His foot has been fused in slight pes planus. His pain is lateral because the calcaneus is hitting the fibula. His sed rates are normal. He's a non-smoker. CT scans show the subtalar joint is fused. The calcaneal fibular abutment is obvious. There's no periprosthetic osteolysis. So stress views show that the ankle reduces. So we're going to stage it. We're going to reconstruct the deltoid ligament again. I do a calcaneal slide just to get the heel back underneath. I took the implant out, put a cement spacer, and we hold it until it is cured. Then we do this double limb allograft weave to reconstruct the deltoid ligament. And we let that heal for 6 to 8 to 12 weeks. So at 2 months, the patient is here, he's stable, and you can see how his operative side alignment is even better than his other side. So in stage 2, we stress it, the deltoid ligament is holding up. And again, we reconstruct it with the modular semi-constrained total ankle system, the Invone 2. Here's our tibial component going up. The talus is seated, poly is placed. And here's the patient at 3 months. And now he's at 1 year, doing well with good movement. So revision total ankles. The paucity of the literature is shocking. There is very little out there on it. And I encourage any of the residents who want a guaranteed publication to please contact us, because we have a lot of this stuff. Long-term data on even the newer implants is lacking. Quality of life and patient-reported outcomes after revision implants versus salvage arthrodesis are lacking. Instrumentation is always improving. We have a long way to go. We can handle the revision load as it is, but I think we're only going to get better. Here's our references. Thank you very much.
Thank you, Dr. Coale and Dr. Brage. That was excellent. And those cases are really a demonstration of tour de force. We have time for questions, a few minutes. You can either just put something into the chat box, raise your virtual hand, or feel free to just speak up. While we're waiting, I would ask you, Michael, you utilize a lot of custom-made implants, which, you know, I envision as being very expensive. So I'm just curious if you know what these implants cost particularly compared to a primary or standard off-the-shelf revision replacement.
All right, so a standard primary in-bone two replacement costs between $10,000 and $12,000 at this time. A custom talus is $15,000. So you're right, it's expensive, and I'm grateful that the institution allows me to do this. I do think that I do hope that with time costs will go down. I do think this is the future. We can certainly reconstruct limbs now that we used to either amputate or fuse. But you're right, it's expensive, and I'm hoping that the newer implants will need less revisions over time. And maybe this is just a phase we're going through, but it is expensive, no doubt.
Any questions from anybody else? I'll just add that UW Medicine is looking to build a pretty sophisticated in-house 3D printing center. I think before we got to, you know, metal implants, it would be, you know, sometime far off in the future, but not impossible. And in the engineering school, they already have capabilities of building macro scale metallic implants. I suspect, you know, outside of compliance and FDA approval issues, they could already fabricate implants similar to what you're using. So maybe at some point that cost could be brought down in that manner. Medical student Upinder Sidhu is asking a good question. What is the time frame from the time you submit the images to the implant companies to get the custom implant back in your hands?
So the entire process takes about 6 weeks. A CT scan is submitted to the company. They often, the engineers will call you and you actually do a webinar with them. And they have this fantastic computer software where the 3D images go up and they then construct the component that you need, and you can fine tune it with them. And once that is done, they send you the plan, you approve it, and then it gets printed. So it takes about 4 to 6 weeks, typically 6 weeks.
Thank you. Anybody else before we wrap it up? Well, thank you, Dr. Coale and Dr. Brage. That was really an informative grand rounds, a procedure that most of us don't know much about, and that was really edifying. So thank you. Everybody have a great day and see you in December.
Thank you.
Thank you.